everyone. Welcome to the Premi Chats, and thank you for joining us here today. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation. CPBF is a charitable organization, and our mission is to empower families of premature babies through support and education. This Premi Chats series is one of the many initiatives we have to bring information to NICU families and healthcare professionals. And today, CPBF reaches an important milestone. We are celebrating our 150th live session. We started our educational series in March 2020 when many programs to support families of preterm babies were suspended because of the pandemic. Since then, we brought to our audience more than 100 guests from 9 different countries, including experts, researchers, healthcare providers, parents, and adults who were born prematurely. Every week, they've shared their knowledge and experiences during our free live sessions. We have covered every relevant topic concerning the well-being of premature babies and their families, such as the impact of COVID, the importance of keeping babies and their families together in the NICU, breastfeeding, kangaroo care, the transitioning from the hospital to home, and parents' mental health. Specialists explain scary acronyms like IVH, RSV, NEC, BPD. Parents share their stories of resilience, determination, and hope. We are grateful to everyone who tunes into our sessions, and we can't wait to continue our educational journey next year. All the sessions are available on our website and YouTube channel. And we are wrapping up our 2021 Premi Chats discussing the outcomes of prematurity, results of continuous quality improvement initiatives. Extremely premature babies admitted to an ICU have challenges in different organ function and development as time goes by. The care of premature babies have improved over the years, with more and more babies now surviving even when they are born at lower gestational ages. In this presentation, we review improvement in outcomes of premature infants admitted to NICUs in Canada over the past 15 years based on our unique quality improvement initiatives. We will also review the role families play in these important improvements. And I have here, join me live from Toronto, Dr. Prakash Shah, who is the Chief of Pediatrics and a professor in the Department of Pediatrics and Institute of Health Policy, Management and Evaluation at the University of Toronto. He's a director of the Canadian Neonatal Network, CNN, and an international network for evaluation of outcomes of neonates, INEO, where he oversees a project of benchmarking outcomes of very low birth weight babies in 11 countries with population-based neonatal networks with a final aim of improving quality of care to babies and families worldwide. He's engaged in several policy and advocacy work with his role in executive committees and advisory board membership as local, provincial, national, and international levels. Dr. Shah, thank you so much for joining us here today. I'm so grateful that you're wrapping up our Premi Chats of 2021, talking about outcomes and what is coming for our families.
Thank you. Thank you. Thank you very much, Fabiana, and thank you very much for whoever has joined for this opportunity. I'm so grateful that we'll be able to share some of the findings and some of the improvement initiatives occurring in Canada and which has led to improvement in outcomes. So my goal is to share with you what has been done, what are the outcomes. At the same time, I'm also hoping that I will tantalize you with what is coming to the future of the newborn care, not only in Canada, but worldwide.
That's wonderful. I will share your slides here, Dr. Shah. And for all of you watching us live on YouTube or Facebook, please do share your comments, insights, and questions. We're going to address them at the end of Dr. Shah's presentation.
Thank you. Thank you. Thank you very much. So just want to highlight that we're looking at a brighter side of the future. And that's what I want to portray here. I want to end the year, which everybody has felt a lot of stress, being stressful, as well as not to our expectation. However, want to shed some improvement color to this talks. So let me start with a slide saying, what is neonatal intensive care? And one of the things that I have learned over the last 20 to 25 years of working in the NICU in Canada is that the only constant that I have observed in neonatal intensive care is change, and change for the better. And I hope I will highlight you how in Canada we have gone about this change to happen. Just to give you a little bit of historical background, neonatal intensive care originated in around 1960s. We are not that old. We are just reaching our maturity stage of 60 years. But every decade has come about a breakthrough. In the initial days, it was babies who were not surviving because of the respiratory maturity. Ventilation came, CPAP came, and helped babies to survive. In 1980, we learned that even though they survive, they end up having significant challenges from the lung perspective. And here comes the antenatal steroid in the mothers to be given to mothers, which improved the lung function. Again, there was a more and more improvement, more and more survival, which comes with more and more challenges. Then came the surfactant to help the babies breathe easier. In 2000, it was nitric oxide and putting the babies on ECMO, which is an extracorporeal life support to make them survive the acute phase of their illness. However, since 2000, there isn't a new intervention that has been innovated or learned to come to our knowledge that is drastically changed the way we manage this baby, except we started to get an idea that we need to be gentle with this baby. We need to avoid mechanical ventilation if they don't need, and we need families into the care of these babies because they are the one who makes it the most important difference. And in the next 10 years, we learned that how can we do what we do better? And how can we do what we know consistently? And that's where the last 2 decades have resulted into plethora of initiatives such as quality improvement. Initially slow to pick up, but it has now picked up the pace that I don't know any NICU in a high-income country that is not engaged in some form of improving quality. And we will show you some of the results of our initiative. And that came from this realization that when time goes, patient care improves. But the patient care improvement is not at the same pace as the science improvement or scientific improvement. And that's where the gap is left, which is how to match patient care with the keeping up with the plethora or sudden increase in knowledge and experience that is being shared by the people. And that quality gap is what we need to bridge to improve the care that we provide to these babies. So what I will share with you some of our experience from Canada. And it came with a concept that we want to build this social capital within the country, because we are a big country in terms of the space, but not as big as many other countries, leaving us with a small number of NICUs that we can work together, we can get together, we can collectively foster and encourage everybody's values and design our system so that it evolves. And the basic of this tenet comes with collecting the data. But we initially thought, okay, yes, let's collect data and then the things will improve. And we quickly realized that data will be collected, it will remain as data. If somebody does not act on it, it doesn't get converted to information, community getting together, collaborate, convert into the knowledge, and then wisdom. And I hope to take you through that journey in a very short part of my presentation, because I want to leave a lot of time for question, answer, and discussion. So this is the map of Canada. We have 31 level 3 neonatal intensive care units across the country. As expectedly, they are all within the border of, within 100-kilometer border of US most of the times, and spread across the country from Victoria to St. John's. And that's where those 31 got together to form what we know today as Canadian Neonatal Network. One would say, I mean, are we same? And as you can see from this slide, that we are different. Some are smaller unit with less than 100 babies, and some are bigger unit with more than 1,200 babies admitted every year. And that then itself comes with a challenge. How do you improve care in all of these units simultaneously or in parallel, so that the outcome does not become the site of care does not become a determinant of an outcome. So we are different. However, we did work together and came together under the umbrella of Canadian Neonatal Network. Our core activity is benchmarking, in which we basically compare each other and learn from each other. We also compare year by year what is happening in the trend of these babies and their outcomes. And with that central piece of benchmarking came all the other activities outside, most important being quality improvement. And I will show you some slides of quality improvement as to what we did and how we did. But be aware of it's not only those things we do a lot of other activities in terms of learning from these babies to improve the care of the coming babies, evaluate the health services as to where are the problems, where are the deficit, and how can we improve, how can we train the new generation of healthcare providers, and how can we help sites individually. So what we publish from the data is information which is in the form of annual report, which we call Canadian Neonatal Network Annual Report, which benchmarks on major outcomes, looks at the trends, and still anonymous reporting, because we just wouldn't like to, at the moment, do not disclose. And that came from the first paper when the data collection started in 1996-97, where you can see what you're seeing here is mortality. On the x-axis are the different sites. On the y-axis is the rate of mortality of the babies admitted to these individual sites. And as you can see, the mortality varied from 1% in site M to 9 to 10% in site N. And the question came, why? In a healthcare system which is completely publicly funded, no potentially limited access issue, why is this variability, and what can we do about this variability? When we looked at it another way, you could see that we would like smaller sites and bigger sites fall into this pink parabol. They should be within that, which indicates that there is some variability, but not significantly different. But there are certain sites which are outside, and this was in 2014. And since then, we have also shown the improvement, which I'll show. But that's where the idea of quality improvement came in 2002. So which we are now as a network 26 years old, but quality improvement around 19, 20 years old. And the idea was that each hospital functions like this. That by the side, we want a whole holistic approach that a hospital embraces in quality improvement, starting from the CEO's office to boardroom to the next being the room of improvement. Because if you can't describe this process of what you're doing, you don't know what you're doing. And that was the concept that we took. So what we coined, at that time in 2002 was named EPIC, which is evidence-based practice to improve quality. And initially it was a 3-year program which we ran. Then we paused for a year and the thing started to go back to where it was. So we launched another one in 2006 to 2008. Knowing what happened to the outcomes and knowing what happened when we paused after EPIC 1, we immediately launched the EPIC 2 and EPIC 3 and currently working on EPIC 4 program. What is it? Conceptually, what we basically planned was to collect information, which is to get data from your site, as well as data and information coming out from literature from different other units. We then process your own data, your own reviews, and analyze and see how are we doing as an individual unit and what are the things that we need to improve, and make a plan. Once the plan is made, the quality improvement activity starts and we get into it, implement it, and then audit and see what we intended happened or not. Did it result in any improvement? If not, go back to the data, go back to the review, and continue this cycle. And this conceptual model is adopted by all the NICUs across the country. And what we learned over the 4 cycles of EPIC was that we reviewed the data, we trained people how to do quality improvement, and proved that it is a scientific process. In the EPIC PHSI, we learned that you need to be immersively engaged, trained, and disseminate. Then only it will work. It doesn't work if I give you a piece of paper and say, look, this is what I did, and it worked. In EPIC 2, we learned, because in EPIC 1, it was a small number of units, but in EPIC 2, it was quite 80% of the units participated, and we learned it is generalizable. With all the quality improvement activity, what happens over time is you return back to the normal or previous state. However, we were the ones who demonstrated that this is a sustainable program. And in EPIC 4, we are advancing it with the help of the families to the new level of comparing things that we 2 units are doing differently. So let me give you the overall results of the entire 14-15 years, because this was the one that was published for data from 2003 to 2017. And what you're seeing here is on the horizontal axis is the admission period year. On the vertical axis is outcome in percentages. And 4 squiggly lines are the different gestational ages. So the bottom one is 23 to 25 week. The green one is 26 to 28. Red is 29 to 30. And the blue is 31 to 32. And what you see over the time is that improvement occurred in every gestational age. So the number of babies surviving without adverse outcome increased over time in every single gestational age. When we looked at individually, sorry, this is small, so this slide may not be visible, but you can see that individually, most of the morbidities, we were able to bring it to the downward trend over the years. Bronchopulmonary dysplasia, severe neurological injury, necrotizing enterocolitis, severe retinopathy of prematurity, and late onset sepsis. The early onset sepsis is flat line, and we need to work before the baby is born in order to have some impact on that. And that plan is going on. But overall, for individual outcomes, we are able to attain 18 to 40% reduction over these years, and ultimately resulting into 20% reduction in adverse outcomes for the babies who are extremely premature, which is less than 29 weeks in Canada. Now, one could argue that, and in addition to that, recently we looked at the neurodevelopmental outcome, which is being done at the follow-up clinic when the babies are 18 to 24 months of age. And as you can see, for each individual outcome, either mortality with significant neurodevelopmental impairment, death after discharge, significant neurodevelopment impairment, or cerebral palsy, in all of these outcomes, we have at least some reduction for all of them. And some are statistically significant, some are not, some may be because of sample size. But it's not only the neonatal outcome, we were able to show some improvement in neurodevelopmental outcome as well. And how do we do this? We basically continuously meet, continuously go over, learn from each other, and get this kind of report out to the people that these are the things that you are, and this is what you need to improve to. So that continuously every unit gets a feedback in their care provision. And what that has resulted, majority of unit, I would say 90, apart from one unit at the borderline, all the units are within that pink parabol that I showed you before in 2014, meaning thereby, to an extent, we have eliminated site of care as an outcome determinant for the babies in Canada. And that's a huge achievement. We are expanding it to the other side because we now learned that we need to work even before the babies are born. So under the leadership of Dr. Sarah McDonald, we are working on what can we do before the baby is born so that the babies are born. In the case they have to be born premature, they are born in the better condition. And we hope that we will see the fruition of that very shortly. Now, one can argue that, well, what you saw was just a time, because everybody should have seen the same improvement because we are better over time. I must tell you, I had the same impression. And then I went back to other countries across the world and asked them that, can you show me your data as to what has happened in your country over this period in terms of the outcome of the babies? So these are the data from 11 high-income countries across the world who has such powerful data. And what you see here is 2007 to 15 and the lines of each country. Now, I must tell you the red is the line, which is Canada. So in 2007, there was a higher number of babies having adverse outcome in Canada. What has happened? Sorry, I need to go back. What has happened over the years because of our quality improvement, we have come down to become the second best. Now you can see so many wiggly lines, but majority of lines that you see have either remained flat in different countries, Canada, Australia, Israel, Japan, Sweden, Switzerland, Spain, UK, Finland, and Tuscany in Italy, or they have gone worse, whereas we are the only one who has gone better over time. And so I don't think it is because of time. It is because of the immense activity that happens in our unit that has resulted in this improvement in outcome. It is the teamwork, it is the multidisciplinary engagement, it's a training, it's a support from your organization, and it's appetite to work to improve. We also learned that it comes as a woven thread only if these factors come into play together. Patient-focused approach, leadership commitment, infrastructure, continuous process of improvement, teamwork, and empowering staff to do the quality improvement. Unless that culture is built in the unit, it takes time before it shows that improvement outcome. We also learned that there are barriers, such as culture. Why do I have to change? Hierarchy, apathy, overload, and lack of engagement. And I think that requires constant reinforcement with the data, information, and training, and we have been able to overcome. What else we learned along the way? This is not a small journey, but we learned that our previous care model was like this. Baby in the center, surrounded by nurse, doctor, therapist, and somewhere in the side is the family. And we learned that was not the correct model. The model should be that parents are primary caregivers. They're responsible for all non-intensive care. They participate actively and engage in the baby's care and do a lot of kangaroo and developmental care. And us, healthcare providers, are teachers, consultants, and helping them through this journey. And under leadership of Dr. O'Brien, we learned that that has led to increase in weight gain, increase in breastfeeding, reduction in infection, reduction in ROP, reduction in incident report, and most importantly, reduction in parental stress. The breastfeeding, baby getting more than 6 feeds per day breast milk increased by nearly 3 times, and formula went down by half in the intervention group compared to control group. So there were a lot of beneficial effect that we learned along the way. So I suspect I'm able to convince you that continuous quality improvement has led to significantly improved outcome. However, where is the newborn care heading in the next 5 to 10 years? I would say we have been better. Starting from hunter or gatherer stage, we are now at the stage of information converting into the wisdom. And that wisdom is what we are applying in the neonatal intensive care. Many of you might have heard, but things are not sci-fi anymore. One of the most major obstacles to families providing care is that baby is hooked up to wires. And there is a lot of work going on with the wireless monitoring of the baby. So you attach these leads, and then monitors are displaying exactly as what they were used to display without any paraphernalia, so that family can be engaged in the baby's care throughout. This is coming. Other thing, many of you might have experienced in the NICU and learned that monitor beeping and oxygen going up and down, and the nurses have to run back and increase oxygen or decrease oxygen. There are machines coming to take over that function of automatically adjusting oxygen. And I don't see that we do not become the primary stay. We're going to use point of care ultrasound very well, wisely, and appropriately in neonatology. We did not use it for anything other than brain before, but now more and more it's being targeted to use for heart, lungs, and intestine. And this is what is going to be the future of the care. And finally, machine learning. Every baby teaches us something. And we want to learn from each baby. And the babies are not linear, that this happened, so this will happen. There's always the complexity that you can see. And that complexity is we want to tap into to learn from those babies by machine learning. There's a concept by Harpreet regarding NICU, where you can see a lot of data is coming from the left side, from monitor, ventilator, blood gas, CPAP, infusion pump, and a lot of other monitors that we put. We want that all come to a data hub, and real-time data streaming with data hub, converting into some kind of mechanism that allows us to have thresholds of alarms. And that we learn from the clinical data on the right side, monitor data on the left side, put it together, and every now and then we get signal to act on or to go and look at the baby as appropriately to predict something way before it otherwise would have happened. So that's probably going to be the future. And I wouldn't say that the future is far away, future is right here. So with that, I would like to stop and have time for the questions. All the information I showed you is available at canadianneonatalnetwork.org, where annually the reports are published that one can see. I would like to acknowledge, sorry for the colors, but a lot of people, the trainees, trainers, group chairs, EPIC committee, meeting committees, and Canadian Neonatal Network family. Also, my God, what happened to these colors? Site investigators, Canadian Premature Babies Foundation, who acts to help us in every step of what we are doing and how we are doing and how we can improve, plus the Mother Infant Care Research Center in Toronto, where I get this information. We want to be like this and not the one that puts the head into the sand and tries to find out what is the better. With that, I would like to stop and take any questions you have. Thank you.
Wow, Dr. Shah, thank you so much for your presentation. First of all, congratulations, this incredible work. I really admire you and your team and everything that is being done in Canada over the last almost 20 years now with EPIC. It's phenomenal work. And I'm very glad that families are included every step of the way. So I have a few questions for you. Well, because you talk about the future, what is coming, which is not very far away, but is almost already here with all this new equipment, the new technology. So I want to discuss with you a little bit about the extreme preterm babies, the 22 weeks, 23 weeks. We've been hearing from US, they're saving babies 21 plus 4 days, 21 plus 5 days. So how do you see this quality improvement initiatives playing a role on saving those babies?
Yeah, I think going down to 22 weeks and 21 weeks is a natural progress that probably is going to happen. 10 years ago, we were not thinking about 23 weeks. 5 years ago, not thinking about 22 weeks. And I'm sure there is things are coming. This kind of immature baby brings on the challenges for the managing these babies is immaturity of all organs, and particularly skin, fluid balance, and all those things need to be very carefully and meticulously managed. We have been getting better and better at carrying 29 weeks and 28 weeks and 7 weeks and 26 weeks. Now we're talking about outcome improvement for 25 and 24, but there is envelope being pushed on the left side as well. So I think at this stage, what we have taken approach is that small baby kind of create teams in either individual center as well as nationally to understand what are the challenges that we will face and how people are dealing with those challenges, and even contacting international experts who have been part of this process that they have been working on to learn from them as to what additional challenges you are facing and how can we mitigate those challenges by improving the care, by learning from each other. Because I don't think anybody knows fully what are the outcomes of those babies when they grow bigger and how can we improve those outcomes. But at least while we are taking care of them in the newborn period, what is the optimal care that we can provide? So by engaging the group of people who are constantly involved in care of such baby is the way to go to learn from them and improve quality as we go along and share our experiences with each other.
Absolutely. So question for you, because I have to ask the question, because you talk about the family, how families were outside the circle and now families are the center of the circle. But we also know all the restrictions on family coming to the hospitals during during COVID for the last 2 years. And now we seem that we are hitting another wave. There are more restrictions might come into place in a lot of NICUs across Canada. So how are we going to mitigate that piece when parents are not fully engaged, are not full in the hospital because of the restrictions with the outcomes of those babies?
Yeah, no, I completely understand. And these last 2 years have been a turmoil for many parents, from going into the phase of I hope nobody was not allowing them at any time, but restricted timing of allowing parents to, or one of the parent to two parents to one parent, or time based and stuff, has created a lot of confusion, lot of challenges for the parents and the family and the staff taking care of these babies. So I would hope that yes, there is a fourth wave on our doorstep. I hope that people do not revert to those kind of restrictions. People have learned and take enhanced precautions both on behalf of the staff as well as the parents to make sure that nobody is put it in a difficult position or position of stress, because you don't want 10 nurses to go off the unit, otherwise the unit will not function. And at the same time, you don't want that baby to not have contact with the parents for any length of time than more than necessary or more than probably feasible for that particular parent. So I would sincerely hope that units do not revert. But I would also like to make that plea that it is important that everybody is vaccinated, including pregnant person. Because what we have been finding is that the population that has not received vaccine is the population which is at the highest risk of either getting it, or if not getting it, for the passing it to the children. So if both families as well as the staff and the hospital administration work together, then probably we'll come to an amicable solution and have facility for those who haven't been vaccinated, and being able to be present in the unit to provide the care to the baby.
Absolutely, so important. So, Dr. Shah, let's talk a little bit about worldwide, because I learned recently that a lot of countries, in low-income countries, have no data. Middle-income countries, the data is not very, it's not like Canada, that we have this solid data from 31 level 3 NICUs in the country. So how those countries can improve care if there is no data?
Yeah. And it is a challenge. I've been working with all those three different levels of the countries, and what we have observed as well, that the data from there is not much available from low income countries. Hardly a small center might have some kind of data available, but not much. And are working with those kind of countries to facilitate not a huge database, but at a small level, start at a small scale. Because unless you come with the data or look at your data, you wouldn't know. I mean, one of the pioneers of quality improvement, Dr. Edward Deming, will say, "In God we trust. Everybody else must bring data."
Yeah, and unfortunately, we still don't see that wide available worldwide in so many countries.
And how can we help them? We don't have to make complicated system, because there may be challenges with technology, electrical power, and all those things. So simple collection forms that they can implement within their unit, and a simple data collection, which doesn't become a tedious job for the people, and then help them how to review it, how to monitor it, how to see the progress, and learn from the data to improve your care would be the best next step that we can have. And we're working with several countries. I mean, we just did a first presentation to 15 CRO countries to see how can we train them to improve quality improvement, particularly with respect to kangaroo mother care. Because in those circumstances, even that simplest of the intervention can save lives. And that's where we are starting.
So can you talk a little bit about that? Because you just shared with me the kind of workshops you provide to those countries, and how can countries with like a high income country like Canada can support those countries?
Yeah. So what we have taken it on our hand is we were approached by the Kangaroo Mother Care Foundation to help, because they have a network of 15 countries in Southeast Asia where the kangaroo care is penetrating. It's gone from high level centers to the somewhat middle level center, but their struggle is to get it to the community level where majority of births are occurring. So they approached us and said, how can you help us to move this bar? Because at this premier institute in our country, everybody knows that we need to do kangaroo mother care. But in the community or SNCU level, people know but not have facility. And how can you help us to develop those, whatever resources we have? How can we work within those resources and show that we have worked and we have shown improvement? So we are working with them we did it for 15 countries workshop. Now we're going to go to individual countries to say that, okay, which are the target population that you want to cover, and how can we help to train them so that they know there are the big 5-6 basic tenets of kangaroo mother care that they need to be reinforcing, implementing, and helping parents to do it. And my hope is that once we run those workshops, that there will be higher penetration of those activity in those particular countries.
No, that is so great to hear, Dr. Shah. One last question for you, because I feel like you're such a visionary. We've been bringing parents to the EPIC conference for the last 4 years, but it's been 3 years that we are more involved. The Canadian Premature Babies Foundation with you, we bring those parents who are actually parent partners in different units across Canada. And how do you see this moving forward? How can parents, not only in Canada, but in other countries, support the work that you do in quality improvement?
Yeah, I think it is very important, because what outcomes that I showed you are the outcomes that clinicians think are the important outcomes. That BPD and brain injury and infection and stuff. What we want to know from the parents, what is important to them. And in our last few years of work, we have learned that for parents, it doesn't matter baby has BPD or not. They want to see the baby's face, and they want to interact with the baby. So they want to see those tubes going out of the nose, and that so that they can talk to the baby and work with the baby. And I think we need to focus on those outcomes in addition to clinical important outcome or administrative important outcome. And that is where the families bring that perspective for us. And that's what we will be looking for now, is that how can I reduce the time that baby spends with this technology by 7 days? If I can reduce it by 7 days, that means 7 more days of parental interaction. And if 7 more days of parental interaction, I could not imagine that it can be not good. It has to be good for the babies, families, and it should make the baby go home earlier. So those are the ones that we will be targeting in addition to what we are currently monitoring, kind of thing.
Absolutely. So, Dr. Shah, thank you so much for joining us here today. Always a pleasure talking to you, learning from you, and really working with you. I'm so in awe of everything that you do, not only for Canada, but worldwide. And for that, I'm very grateful.
Thank you very much. Thank you for giving this opportunity. And I hope I have inspired people to be engaged again, to work with the healthcare providers to improve the outcome. And happy holidays to everybody.
Yes, happy holidays, Dr. Shah. Thank you so much.
Thank you. Thank you.
And to all of you watching us live on YouTube and Facebook, thank you so much for joining us here today. In 2022, we will be live streaming on Twitter as well. And the video of today's session and all the other videos from our live series are available on our website, which is right here, the CanadianPremies.org. If I find the link here you go. And I really want to thank our sponsors, AstraZeneca and Waterwives, for their ongoing support to our education sessions. And we are a charitable organization, and we believe that through support and education, we can empower families, ensuring they are ready to care for their babies. Visit our website, consider making a donation. Together, we can create a brighter future for all our families. And we'll take a break, and we'll be back with our live sessions on January the 14th. So happy holidays to all of you and your families. And we wish you, on behalf of the whole CPBF team, a healthy 2022. Thank you, everyone.